Welcome to Blooducation Baristas. I am your host, Dr. Daniela Hermelin, serving you piping hot transfusion news. I am the Chief Medical Officer of Impact Life Blood Center and Assistant Professor of Pathology at St. Louis University School of Medicine. I am privileged today to have my friend and colleague, Dr. Brian Adkins, who's going to be discussing a really challenging topic personally I have had, which is understanding, diagnosing, managing hyperhemolysis syndrome, which is a catastrophic anemia that occurs after a transfusion where we have hemolysis of both recipient, patient, and donor cells. So it is a privilege to have Dr. Adkins join me today to talk about hyperhemolysis. Hi.
Hi, Daniela. Thank you.
Thank you so much for joining me today. I think that this is a topic that you're going to really help a lot of people shed some clarity, especially, just to be thinking about it when it happens. But before we get started, I have had the privilege of being able to spend some time with you, partnering with you in trying to recruit pathologists to become the next generation of transfusion medicine specialists. And I'd love to hear a little bit more about your story. How did you become a transfusion medicine specialist? I think you were supposed to become a DJ. I see you in your DJ mode right now with your mic and your headset. So tell us a little bit more about how you got to transfusion medicine from DJing.
Yeah. Well, I'm a professional doctor. I've never been paid to DJ, so that's a big delineating factor. But no, I went to college and I was interested in a bunch of different things. I DJ'd at the radio station there, and then my parents were like, "Oh, you should go into biology or something like that." So I ended up deciding to go into medicine. And then from there, I really wanted to do family medicine because I grew up in West Virginia, and then ultimately really fell in love with pathology. And it's funny because I liked like the coag cascade lecture and the transfusion lectures in my second year. So subsequent to that, I was, back and forth to APCP. I initially wanted to do GI pathology, and then ended up really loving my transfusion medicine and coagulation rotations. So it's sort of a through line that I was like, oh, this is what I'm really supposed to be doing. And so I was at Vanderbilt for residency, and then ended up going a little closer to home, University of Virginia, for fellowship. I did a hematopathology fellowship and then a transfusion fellowship. And I always tell people that, when you're growing up, you're worried, will I ever be ready? But whenever you've been in training that long, people are like, oh, will you ever get a job? So
yeah, I hear that.
Yeah,
but you have a fellowship in both hematopathology and transfusion medicine. And I always joke around that if residency can be like college where you major and minor, I can't imagine a better fit, or you can double major. So you chose both of those, which are really a beautiful synergy, and it helps very much to have both of those under your belt to do the job we do.
Yeah, I think having a good understanding of both sort of just benign and malignant hematology is really important, especially as a lot of like malignant conditions associate with like autoimmune hemolytic anemia or, ABO subtyping issues, things like that. And having an understanding of not only the blood that's circulating, but where it comes from.
Absolutely. And it helps as physicians that we can look at things inside out, especially as we may be performing procedures, apheresis procedures, we're reviewing the patient's chart, we're examining the patient, we're looking, but then you and I take a look at the peripheral blood smear and understand what's going on really within the patient. I love that kind of association that
Definitely.
we do both of that. Well, let me ask you, how did you become interested, fascinated, and then kind of becoming an expert in this area of hyperhemolysis?
So really, it was in residency. I think in transfusion medicine, uh, generally we're taking care of patients with sickle cell disease. So that's an area that we really get interested in and care for the
Yes.
group. And Quentin Eichbaum invited me to work on a project because when I was in residency, there was a French group who put out some guidelines and criteria for diagnosing a delayed hemolytic transfusion reaction, and
Okay.
sort of introduced me to the idea of hyperhemolysis. And he had seen a case, and then we subsequently had a case on service of
Mhm.
possible hyperhemolysis. And it was actually really important that we differentiated it. It wasn't. And we were able to do a red cell exchange for acute chest. So that
Mm,
worked out for that patient, and they got what they needed.
got it. Yeah, so let's then just jump right in. For someone who's never heard of this word before, hyperhemolysis, you know, what exactly is that? And why is it something we really need to understand and be able to recognize right away?
Yeah, so it's a really devastating transfusion reaction. It's a situation where a patient who requires red cell transfusion subsequently destroys not only the transfused cells, but their own red cells as well, because of some sort of immune dyscrasia. And with that, it's really important to avoid further transfusion and offer them support as they can become very anemic.
Mhm. I like how you started off telling us that this is actually a form of transfusion reaction.
Mhm.
This happens after transfusion. This
Yeah.
isn't something we're going to see just come in someone's hemolyzing, and we call it
Mhm.
hyperhemolysis. This is something that happens after a person receives a transfusion and we see some type of hemolytic episode happen.
Yeah,
And we're going to call it hyper because it's just massive.
exactly.
Okay. And as you started out by explaining even your role in being involved in this, it came about your understanding within sickle cell disease.
Mhm.
So, in your experience, and actually, I've only seen one real hyperhemolysis, and also it was in the context of sickle cell disease. Do we see this in other patient populations?
Unfortunately, yes. If you look at the literature, we did a systematic review a couple of years ago and
Mhm.
showed that it can associate with all kinds of different things. Patients with lymphoma, even patients with like chronic anemias. Anyone who can get a red cell transfusion could possibly develop hyperhemolysis. That being
Mhm.
said, it is significantly more common in patients with hemoglobinopathy, like sickle cell disease, or patients with like thalassemia.
Mhm. Mhm. So would you say we probably wouldn't see this in an individual with a first-time transfusion? Is it someone who's been
So
transfused multiple
that's a
times?
great question to bring
Mhm.
up. A
Yeah.
lot of these patients have a history of transfusion, and with that, a
Yeah.
history of antibodies.
Okay.
So a large proportion of these patients are going to have a transfusion history. So I would not anticipate it in a first transfusion. I don't know if that's been described, but
Yeah.
in general, these patients have had prior transfusions, and that's also why it's so difficult because occasionally the screen will be negative, or the DAT will be negative as well.
Okay. That's also helpful. So we're thinking about this, a patient who has received multiple transfusions and probably has an underlying alloantibody.
Yeah.
Okay. So that's kind of the population. Um, what's striking to me is you have this patient, you transfuse, and then we say we see either a drop in hemoglobin, or would you say we don't see an increment in the transfusion?
So whenever we were writing our paper, this was something the reviewers were sort of like hammering on.
Okay.
So what you expect is the hemoglobin should be less than the pre-transfusion value. So it's not just a bump, but an additional drop. And
Hmm.
there's a nice paper from Gardner, I think British Journal of Hematology in 2015, where they say a 25% drop in hemoglobin. That's suggestive of a delayed hemolytic transfusion reaction, but we also use that criteria whenever we're looking at hyperhemolysis.
Okay, I like that. It's nice to kind of hang your hat on a number
Yes,
because
definitely.
again, I think what's challenging is, you know, we might need to differentiate this from red cell refractoriness. We don't talk about that much, you think about platelet, but
Mhm.
there are situations where a person is transfused and we don't see an increment in
And they
hemoglobin.
clear them all. Yeah.
Right, right. Or they've got a big spleen, and sometimes
Mhm.
that happens as well. So I wonder, again, that if we're going to kind of check the boxes, so this is going to happen in a patient who is recently transfused, most likely has been transfused multiple times in the past, and probably has an alloantibody.
Mhm.
And we're going to see a drop in hemoglobin, at least 25% below the pre-transfusion hemoglobin.
Mhm.
Did I get that right so far?
Yes, perfect. You're right on
Okay.
track.
Okay, amazing. So now we have all of those kind of checks on the boxes. Is there anything else in this point of time where we should say we need to just think about one more thing before our brain jumps to hyperhemolysis?
I want to know if they're actually hemolyzing.
Okay.
So we need to look at some hemolysis labs and demonstrate that there's hemolysis happening. Now, this can be really difficult. It's always easy to say, oh, check the hemolysis labs. And it's like, well, which one? So if this is a patient where we're concerned, if they have like a history, I like to trend in LDH as it should really go up.
Okay.
You can look at haptoglobin, but in
Mhm.
patients with chronic hemolysis, their haptoglobin is going to be depleted at baseline.
Okay.
A plasma-free hemoglobin can be really good if your hospital has access to that.
Mhm.
The university hospital down here doesn't have it, but our children's hospital has it.
Okay.
Um, so what plasma-free hemoglobin evaluates is once the haptoglobin has bound all the free hemoglobin, the rest of it remains in the plasma. So that's often used for patients on like ECMO and stuff to track hemolysis. So that's a
Mhm.
really nice marker. And then also you can look, and another thing to keep in mind with haptoglobin, it's produced in the liver. So if someone has bad liver disease, their haptoglobin may be low.
Mhm.
Similarly, your bilirubin may be high if someone has liver disease.
Mhm.
So again, it's sort of more a clinical gestalt.
Yeah.
And I think LDH is probably the best thing, sort of trending in LDH if you can do that.
Got
If
it.
you can't trend it a super high LDH and a drop of hemoglobin of 25%, then I feel like you're on the right track.
Okay. Well, you definitely started us out with just how to recognize that this is
Mhm.
happening and what we should be kind of checking off in the first
Yeah.
few minutes. Um, but when we think about it, I know that we sometimes need to take a step back and just also think about some pre-analytical or other differentials. Is there
Yeah.
something else that we should consider and not just jump to the zebra hyperhemolysis?
So I think you should obviously look at your whole patient. There's nothing that really predicts hyperhemolysis, though
Mm-hmm.
it is more common in patients who have had it before. So if
Okay.
this is a
Oh,
patient where you have a history of hyperhemolysis and suddenly their hemoglobin's down after transfusion, okay, I'm scared. I want to work this patient up.
okay.
Um, yeah, you should always be considering like pre-analytic variables. Was it a bad stick? Was it a
Mhm.
specimen mix-up? Something like that.
Yeah.
So it's always very reasonable to redraw the lab, repeat the lab, take a look at the smear, see if there's something going on. But if it lines up and all the hemolysis markers are abnormal, then I think it's fine to sort of follow that.
Okay. Sounds good. So just to summarize, what we would call in our lab to do a clerical check, make
Mhm.
sure that the right blood went to the right patient, that we, making sure that all the patient's information and identification is correct, and maybe also that we're not dealing with an acute hemolytic
Yeah,
transfusion
certainly.
reaction. Yeah.
Certainly.
Okay. Perfect. Okay. Well, let's just say though, okay, this looks like
Yeah.
hyperhemolysis. What do we have to do next?
Okay, so we'll finish up the labs. I always like to check a reticulocyte count because
Okay.
often not only will the circulating red cells be cleared, but there'll be a reticulocytopenia, and it's unclear why.
Hmm.
Um, But then after that, you sort of have to get a bunch of teams working together really quickly. So when
Okay.
we think about the pathophysiology of hyperhemolysis, it's sort of unclear, but there are a lot of described sort of mechanisms.
Okay.
So sort of the old school thinking is that there's some sort of transient autoantibody. And as we can't really demonstrate an antibody, it's unclear what the prevalence of that is or if that's really happening. I think the two sort of more contemporary descriptions deal with both macrophage activation and complement activation. So there's a nice sort of brown stain study that Wynn did showing basically activated monocytes clearing red cells in the spleen of a patient with hyperhemolysis. So I think there's certainly a component of macrophages sort of on amok trying to clear all of the red cells. Also, we have to think about complement. So whenever we have hemolysis, free hemoglobin can activate complement. And then there can also be complement deposition leading to a non-antibody mediated clearance of red cells. It can lead to opsonization clearance of red cells. So we've got all this inflammation with complement and extra macrophage activity. So what we really need to do is figure out how we're going to treat this patient, right?
Yes.
So thinking about all that, we have to get a lot of different treatments on board.
Okay.
And in order to do that, you got to get a lot of people to help you out.
Well, can we just take a pause because you've taught us so much in just that short 2 minutes, which is somehow in this multiply transfused person at risk. They have a wonky immune system that gets activated.
Yeah.
And that activation leads to destruction of the red cell, both self and non-self, donor and patient and recipient. Yeah. And so it may not be antibody mediated. This may not be a new antibody or an antibody that's binding to the red cell, but this might be driven from macrophage activation. I think of Pac-Man, right? So like those little Pac-Mans starting to gobble up the red cells. And then also perhaps even complement activation. And as you mentioned, the free hemoglobin can activate complement activation.
And to your point, antibodies play a significant role. If a patient has a history of an antibody, you can certainly see, oh, so sorry.
No problem.
The scariest pager noise.
Yeah, no problem. It shows you're a real doctor.
It's an FYI page, so we can get back to it. But ultimately, with this, you can have an antibody triggering like a delayed hemolytic transfusion reaction, and then that sort of triggers the hyperhemolysis process where it's activating the immune system in addition to sort of a more run-of-the-mill DHTR. Okay.
But in these cases, like you mentioned very early, we can have a negative DAT. Both IgG and C3 can be negative. And it could be even though they have an underlying allo or an alloantibody, we might not see new antibodies form. Okay.
And that's the really difficult part. About half of patients will have a positive DAT, half of patients won't. And it's unclear if that's due to rapid sort of destruction of the red cells, and that's why we're not seeing the DAT.
Yes.
Or if there's just something else going on. And I think that's the really challenging thing about hyperhemolysis is we may be describing a heterogeneous group of pathologies. And I think that's reflected in sort of the shotgun way we treat these patients, which we'll get to.
Yes. I have to say that you saying this could be heterogeneous, that actually takes a few bricks off my chest. Truly, sometimes as clinicians and diagnosticians, we think that there's just one disease, and that's why you have to just you use the word gestalt, look at it all and think through it. And not everything presents perfectly or similar every time.
Exactly.
And not to be afraid or surprised that the DAT is negative. Like you mentioned, we could think, well, it's because they're all hemolyzed, but could be a DAT negative hemolysis happening. And also you talked about the importance of doing a reticulocyte count. So let's like keep that in the back of our minds and talk through that even more, because I know that is, quote, part of our hemolytic indices.
Yeah.
And
So,
why that might be, you know, something we want to
challenging.
keep our eye on in terms of like also driving home the diagnosis of this.
Yeah. So whenever we did our systematic review, we wanted to use really strict criteria. So this is the paper I did with Jeremy Jacobs in 2023 and a big group of folks that we work with. And really, we wanted to use strict criteria to exclude non-hyperhemolysis cases from our review. The thinking is that there's some clearance of the erythroid precursors due to this sort of ramped up immune system. So I wouldn't call this a sine qua non or whatever. I think that's Latin. I'm from West Virginia, so anytime I say stuff like that, I feel a little weird. But anyways, yeah, you would expect the reticulocyte count to go down, which is strange. And the reason for this is unclear. We're thinking that it's probably destruction, but it may be also you've had a transfusion and that may have dampened your erythropoietin axis as well.
Okay.
That being said, you don't certainly have to have it, but it is nice to see. Again, I think this is sort of heterogeneous, but if you do see this, then that is supportive.
Right, right. But what about the opposite? If you see a high reticulocyte count, can you say this isn't hyperhemolysis syndrome?
I don't think you can.
Really? Okay.
Really, I think you have to follow it. And sometimes if it's not decreased, it's an inappropriate response, just like not an elevated reticulocyte count. If you have like a really robust reticulocytosis, I think you sort of have to think about it a little harder. And it really just see how the patient responds to intervention.
Yeah. Okay. Well, I'm feeling good now where you could take me to bringing in the whole team on this.
The whole team. Yeah.
I'm ready to speak to the entire team. So you're saying we can't now like treat this patient on an island, which we normally don't do.
Yeah.
But this is going to take a group of people to help. So who are those other team members?
So I always have to lean on my hematologists for this. So they're at the bedside, they're seeing the patient, they're saying, well, he looks okay. Or this patient does not look very good. So definitely making sure hematology knows what's going on and sort of being that transfusion expert for that is super important.
Okay.
Additionally, you may have to order a lot of sort of expensive or sort of different like monoclonal antibody type drugs. Okay. So if you're going to order a drug that may not necessarily even be on formulary at your hospital, it's really important to involve pharmacy as soon as possible. And then just letting your blood bank know, hey, if they order another transfusion, make sure you shoot me a page because we need to talk about it.
Okay, that is super important because I don't think we've really made a big, bold red sign about this yet, which is the most important thing in diagnosing this is not transfusing anymore.
Hold off.
Yes. So hyperhemolysis, don't transfuse. Right? So that's like the first message. And once you kind of declare that this is what you think it is, I would say the first form of therapy is actually to not transfuse.
To avoid transfusion.
To avoid it. And we've got to be thinking about something else. Okay. So you pick up the phone, you call your hematologist and you say, I think based on these parameters, we're dealing with hyperhemolysis, stop transfusion, and we might need to add on board some of these monoclonal antibodies. And in your paper, you discussed many different types that are going to be associated with either, trying to, how would you say it, sort of inhibit the complement pathway, which you mentioned maybe like eculizumab. And then there's to inhibit the macrophage activation, so TOSI. What other things would we want to be thinking about in terms of the different parts of that pathogenesis?
So I think we start out typically with the more traditional drugs.
Okay.
So that's corticosteroids. That's sort of a general, knocking out the inflammation affecting the macrophages.
Mhm.
That's what we use for like autoimmune hemolytic anemia.
Mhm.
One consideration with steroids is you can precipitate a vaso-occlusive crisis in sickle cell disease.
Okay.
So oftentimes the hematologist will have some reservations about giving steroids. However, again, that's when you have to have a discussion with your team. Like this could be a potentially fatal hemolytic event. If they were to additionally have a vaso-occlusive crisis, we're right here. We have all the support that we can give them.
Mhm.
So just using them judiciously and really thinking about it. IVIG,
Okay.
we like to do as well. That sort of confuses the immune system a little bit.
Mhm.
It also blocks the neonatal FC receptor, which is what recycles IgG circulating in the blood. So that's going to lead to some clearance of any IgG antibodies that could be causing some of this.
Okay.
And then before we get, oh, so sorry, I do have to take this. Do you mind?
Take your
All right,
time.
thank you.
We're real live doctors who have to take call at times, so totally understand. But this is really fascinating, to go through these different types of drugs that we're going to be using to combat hyperhemolysis, and then again, not to transfuse at this moment. But I am curious to see if transfusion may play a role and how we might slowly transfuse a person because they have a drop in hemoglobin. What else can we do at this time? So very, very interesting. Well, I'm sure Dr. Adkins will be back with us in just a minute. Thank you all for your patience. Maybe it's my turn to take a sip of coffee as well.
All right, I'm back.
Perfect timing.
So we were talking about steroids and then IVIG.
Mhm.
And then also for the immune system, we want to sort of act on these underlying processes, right? So we're thinking about the complements. We can use eculizumab, which is a complement inhibitor. And a lot of studies have shown success in response to eculizumab. So we tend to do that. And we'll often employ that on day one or day two, sort of as soon as the pharmacy can get it for us. So that's a big thing where we have to get the pharmacy involved, because occasionally you have to get authorization to use those medications. Also, patients will need to be vaccinated for like meningococcal species and other splenic or complement cleared things.
Right.
And then we'll use tocilizumab, which is an IL-6 inhibitor. IL-6 activates monocytes. So if you can block that, then the thinking is you're sort of intervening to stop that overactivated macrophage. And again, studies have shown great success with that as well. One difficulty in kind of determining what is really making the difference is a lot of papers that we found and a lot of our practice is sort of using all of these concomitantly.
Yeah.
So again, these are all expensive medications. So really, this is something where once you've sort of made the diagnosis, it's really time to step up and offer the support the patient needs. I will say with eculizumab, some sites will only give it if the complement on the DAT is positive.
Interesting. And comp C3.
Yeah, C3.
Okay. So we've bringing in members of our team to help us. Don't transfuse. We need to add all of these medications on board right away. We're adding heme. We're adding pharmacology. Is this an ICU type of patient?
Yeah, this is an ICU stay. You really need to be monitoring their vital signs, their respiratory status. Are they oxygenating? And we like to talk about all these big fancy drugs, but there's some really basic things that we need to keep in mind too. Is the patient getting oxygen? Are they on like 2 liters or 6 liters, something like that? Nasal cannula. So offering that support. Because we really need to be oxygenating. That's why we need the red cells. In addition to that, we want to limit blood draws. we can really, bleed somebody dry in the hospital doing all kinds of unnecessary testing. So once you've made the diagnosis, you're sort of more following the patient's overall status as opposed to just following a number. We're not going to draw 5 hemoglobins in a day. We're going to draw 1 a day and see where we're at.
Right.
So limiting blood draws using pediatric tubes, and then also trying to use bedside, maybe point of care hemoglobin readings, because that takes a smaller volume. It's a little less accurate, but maybe that can get us there,
Yes.
And
I
then,
love
go
that.
ahead.
Just like, I just love us being more mindful of patient blood management strategies. I wish we did this all the time. But of course, when we really need to be doing it, we need to add it, like you're saying, to almost like the protocol.
Yeah, exactly.
Yeah.
And it is in our protocol.
Right.
Because, these are inexpensive things. These are things that really make a difference.
Right.
And, you can make that kind of intervention just at the bedside and everyone can sort of help out.
Well, don't throw rotten tomatoes at me, but is there a way that you can transfuse in this case? We just said avoid, but what do you do when the person's hemoglobin is 4?
Yeah. So bear in mind that a lot of these patients have chronic anemia, so they can tolerate a lower hemoglobin.
Okay.
Their 2,3 DPG and things like that has sort of acclimated to them having like a baseline hemoglobin sometimes of like 5 or 6. That being said, if you're following the vitals and the vitals are going the wrong way, you may eventually have to transfuse. So with that, you want to wait until you've gotten all your drugs on board. You want IVIG, you want steroids, you want eculizumab, you maybe want Toci, and then you'll transfuse.
Got it.
We showed in the systematic review that these patients will actually have longer hospital stays if they get transfused.
Interesting.
It's unclear if that's because they got so sick that they needed a transfusion. That's why they're still at the hospital, or if the transfusion itself is making things worse at that point.
Got it.
But basically, you want to have all of your immunomodulation on board before you attempt the transfusion. And you want to transfuse slowly. You don't want to be slamming the units in or something like that. You want to transfuse slowly over a course of 4 hours and monitor the patient throughout.
Beautiful. That was really helpful. So stay calm. Don't transfuse. Get those other drugs on board and just let things progress.
And we have some more tools in our armament. We're not done yet.
Tell me what are other tools?
We want to buoy the patient's intrinsic red cell production as much as possible. So we want to get an erythroid stimulating agent on board, something like EPO or darbepoetin. That actually leads to longer circulation of red cells if those are up as well, it's been shown. So that can potentially help with clearance even. And then in general, with our sickle cell disease patients, they're iron overloaded. They don't need any iron. But in patients who do have concomitant iron deficiency, giving the iron infusion, look at B12, look at folate. And again, these are labs you want to get up front. So you can not only start the medication or the intervention, but you don't have to draw additional labs. So that's part of sort of the battery of tests that we want to get at the beginning. We want to get hemolysis markers. We want to get metabolic markers. And then we want to really stop testing if at all possible.
That makes a lot of sense. What about plasma exchange? Does that have a role in this situation?
Oh, plasma exchange scares me so much in these patients. So I come from the peds world where we do red cell primes. In the adult world, I think they're a little more comfortable with attempting it. And there is published literature of some success with plasma exchange. One difficulty is, do you want to prime? If you're going to prime, that's another exposure to red cells. And there have been at least anecdotal reports of patients not doing well with that. That being said, some sites say, hey, we're just going to go for it with the plasma exchange without the prime. So I think it's difficult and sort of risky, especially as the package insert for the Optia requires certain hematocrit requirements. So if you have an IRB, I think that would be reasonable. but it not something that I would do necessarily. I wouldn't be a cowboy with this stuff, you know.
Mm-hmm. So you're saying that would be something you put in the same category as transfuse. It's like a plan B, F.
Yeah. That's a backup or
Yeah.
a backup.
Got it. So I think you really helped us to understand the therapeutic approach in navigating this, which is you start with your steroids, IVIG, and then a C3 complement inhibitor, and then your IL-6 inhibitor.
Mm-hmm.
So that's very helpful. Monitor.
Mm-hmm.
How long do you think it will take to actually see a response? Does it take 24 hours?
Usually it's a couple days to a week is what we've
Okay.
seen. So the whole reason for the development of this protocol is that we were running into these really challenging patients and we were sort of having to do things on the fly, you know. But we have a large catchment here in Dallas, so we see a lot of patients. We probably deal with, I would say, 4 or 5 of these cases a year.
Okay. Wow.
So our outcomes were not where we wanted them to be. So we put together this protocol, and I think that things have actually really improved, and we're seeing a lot better outcomes with our patients, which I'm so thankful for. But yeah, it is a hospital stay. You're going to the ICU. You're getting down to a hemoglobin of 3.5, and maybe you're getting transfused and coming back from there. But that's something to bear in mind, especially in managing these patients and in the medical literature. There's a reporting bias where the patients who do expire secondary to hyperhemolysis often don't get reported on. This is occurring, and this is not somebody getting excited about writing a case report, right? If you look at the FDA CIB-MTR reports for transfusion-related fatalities, there's often a small number of hyperhemolysis cases reported. So this may relate to some people not understanding that it's a transfusion reaction, but there is an underreporting of hyperhemolysis, both to the FDA as well as in the medical literature. So bear in mind, this can be a potentially fatal event, and patients often don't do very well. So again, that's why I think it's so important to get all this on board. And anecdotally, I will say that if there's a delay in implementing sort of the full treatment of hyperhemolysis, that often associates with longer hospital stays or more severe outcomes.
Yeah, these are wonderful points that you're making. First of all, we all know that transfusion reactions are probably underreported in general.
Yeah.
But I think that because this is a challenging diagnosis, it may even be even more so underreported. Let me ask you a question. We're thinking about a timeline. When this happens, meaning we see a precipitous drop in hemoglobin, when do we see it? Is it within an hour, 6 hours, 12 hours? Because I think we talked about the differential of an acute hemolytic transfusion reaction, but sometimes I think we might also think about delayed as being part of the differential. Is that an easy way? Is that timeline so easy to differentiate?
So again, we sort of have to lean on the literature, which is very heterogeneous.
Okay.
Practically, I think you tend to see it more within a couple of hours to a day, though it can be seen within like a couple of weeks. I think ASH says up to 21 days in their sickle cell transfusion guidance. So it's something to keep an eye on. And I think it depends on what the triggering event is. If it's sort of unknown and it's just the body doesn't like red cells, that tends to be more within a day. If it's a delayed hemolytic transfusion reaction that precipitates hyperhemolysis, I think that would be more in the area of like weeks or something like that.
Right. Okay. So again, going into this idea, we're dealing with something heterogeneous, but we're going to go back to the main elements. This happens after a transfusion. We see a precipitous drop in hemoglobin, 25% below the baseline pre-transfusion, and that these individuals may or may not have a low reticulocyte count. And these individuals probably do not have a new alloantibody formed.
Mm-hmm.
So, but it makes it challenging, when you have
certainly.
these other. Now, because this happens a little bit more in the sickle cell population, can we now take just a few minutes to focus on maybe laboratory perimeters or other elements that we should
definitely
be thinking about in this population? So, I think in your paper, you really talk about also when we monitor the hemoglobin S versus hemoglobin A, that might also help us to identify and make this diagnosis and monitor the diagnosis.
Yeah. So I think as this does occur most frequently with sickle cell disease, this is our population that we're always thinking about with not only chronic transfusion, but chronic inflammation. This is a setup for hyperhemolysis. That being said, we don't want to jump to the zebra. We want to think about what's common. So I think acute chest is incredibly common in sickle cell disease. Acute chest can associate with drops in hemoglobin. So can a lot of the other sort of acute manifestations of sickle cell disease. So you really want to rule those things out before you start sort of chasing hyperhemolysis as the diagnosis. And then we also want to look at our laboratory values. Again, haptoglobin is chronically low in patients with sickle cell disease. Not only can transfusion kind of transiently affect the haptoglobin level, they have chronic hemolysis, so their haptoglobin will always be depleted. So you can't really rely on that value, right? So you bring this point up, and I think it's very important, is we can look at the hemoglobin electrophoresis. Many sites have a rapid or more rapid kind of test, like a capillary electrophoresis or a high-performance liquid chromatography test where you can get it same day. And if you look at the percentages, the hemoglobin A should drop. That would mean that the unit of blood that's been transfused is being cleared. So what's hemoglobin A? Whenever we think about sickle cell disease, it's a beta globin abnormality. Beta globin's on chromosome 11. They have two abnormal beta globin genes, either two hemoglobin S or one big like thalassemic deletion and then an S. So they don't have any native hemoglobin A. So if we look at our laboratory test and show that hemoglobin A has dropped precipitously, that means they're hemolyzing the unit. And one thing that's interesting is you can actually see that sort of shift depending on how much of the native cells are being lysed as well. And that's sort of more difficult to suss out because HPLC and capillary electrophoresis only give you relative percentages. They don't tell you the amount of hemoglobin that's present. But that's a good hint if the hemoglobin A is dropped that the patient's hemolyzing the unit.
Right. So monitoring.
That wasn't my idea. I have to give credit where credit's due. So there's a really wonderful French group that looks at sickle cell disease and has studied a really large cohort. And they put together a nomogram, which is available online. And you can sort of type in your patient's information, and it'll determine a likelihood of a delayed hemolytic transfusion reaction.
Okay, so by maybe monitoring that hemoglobin electrophoresis, by monitoring the quantity of hemoglobin A and hemoglobin S pre and post transfusion can help you also in understanding if this is a hyperhemolysis diagnosis. And that's because, again, we shouldn't have such a drop in our donor red cells.
No.
And because in hyperhemolysis, we see hemolysis occurring in both donor and recipient, of course, on the donor side.
Yeah.
And so, but how are we differentiating this from a delayed hemolytic transfusion reaction where also it would occur with our donor cells?
Yeah. So again, that tool and a lot of the tools that we have available are things that have been developed to assess for delayed hemolytic transfusion reactions, which are significantly more common.
Yes.
This is when you really have to sort of lean on the whole clinical picture and have an idea of what's going on. So if the patient is stable, they have a positive DAT, there's a new antibody discovered, and the patient's walking around, looks fine, feels fine, wants to leave so they can go play Minecraft or something. That's a very different patient than the hyperhemolysis patient who is coming in, having vital sign abnormalities, maybe some confusing things happening on their immunohematology evaluation as well. So again, it's more of a gestalt, which is it's not a satisfying answer, but it's not sort of an easy diagnosis to make, I think.
Yes. And that's why you're here to help us. And your publication is so, it's great.
Oh, thank you.
On the How Do I, and I'm going to put the link. It's an open access article. So thank you for that gift, by the way.
Oh, yes. Thank you, UT Southwestern. They have an agreement with, I think it's Elsevier or no, Wiley, excuse me. Sorry, I said that, Wiley.
No problem. Well, thank you, UT South Texas, for allowing this, because truly, like, for all of us to have access to this important information when we need it is just vital. I think, though, in 2025, to really make this work, and probably one of the most important things you did was to create a protocol, is just having a really good IT system. Did you create like an order set and a whole mechanism for people to, I don't know, how do you, is there a place for that?
That's a good idea.
Yeah.
We triage a lot of our products prospectively down here. And I think that's sort of the bread and butter of our practice, in so much that's how we get involved with a lot of cases. So we triage single unit FFP transfusions, which likely aren't indicated. We triage emergency department platelet transfusions to try and catch TTP or ITP cases. And we actually triage every red cell that goes out to a patient with sickle cell disease.
Okay.
So with that, we're really able to sort of pin down whenever a patient's developing these symptoms. And then we also, I think, have a good working relation with our relationship with our hematology colleagues. We are quick to say consult hematology if there's a complex case. And with that, we also have weekly conferences with them. So I think it's just an ongoing conversation. Though, to your point, I think building something within Epic could be good. I believe the Emory group spoke about this at AABB a couple years ago. They have, I think, that nomogram actually built into Epic, where they're able to follow the hemoglobin A level, and maybe some other things that would indicate that a patient's having a delayed hemolytic transfusion reaction or hyperhemolysis.
Yeah, that's incredible. I do think we need to be using digital tools to help us more often now, to make our lives more efficient.
People get tired. The computers are always, like, I guess, doing their thing.
Yeah, but it just helps us monitor the patient and create better dashboards, etc. But can you tell us what it means when you say you triage patients with sickle cell disease and monitoring their red cell transfusions? Like, what does that actually look like?
So this is work that the residents really carry, and it's an opportunity for them really to have some responsibility and some interaction with the clinical teams. So anytime a red cell transfusion is ordered for a patient with sickle cell disease, we have a note in our laboratory information system that they have sickle cell disease and to contact the resident. So the resident reviews the chart and takes a look at the patient. So we have a hemoglobin threshold of 5 for patients with sickle cell disease, because we don't want them to have a DHTR. We don't want them to alloimmunize, and we don't want to further their iron overload. So unless a patient is under 5 or has acute chest or something like that, we would not be releasing a unit. And with that, that also helps acute chest, especially because we would prefer to do a red cell exchange, because that'll take off some of the cytokines in the plasma. That'll more efficiently reduce the hemoglobin S level. And as acute chest is the #1 cause of death in sickle cell disease, that's going to be more beneficial to the patient. So that's how we triage products. And it is a lot of work. And I'm very thankful that we have fantastic residents here who make that difference. But I think it also leads to more involvement from the transfusion service in the care of sickle cell disease patients, and
Yes,
hopefully
absolutely.
leads to some better care.
This is remarkable what you do. Honestly, it would be fantastic if it could be mimicked, but you have worker bees.
I know,
Really,
and we're
really
so
good
thankful for them.
worker bees.
And
And
I
yeah,
really have to just sort of go off on like how great our residents are. They're so hardworking.
go ahead. Let's
I'm so
just,
thankful for them. They're so smart. They do the best job. I'm so proud of all of them. And some of them even like it so much that they go into transfusion. So that's good too.
well, I'm sure working with you, it's a wonderful opportunity, and you kind of shower them with that passion and energy. But I think that what you've developed at your organization also allows you to be acutely aware and pick
Mhm.
up if hyperhemolysis syndrome could
Yeah.
even happen. So that makes it even one step like on your radar.
Yeah.
That's great. Well, we really covered a lot. We covered what hyperhemolysis syndrome is. Again, it's a transfusion reaction. It's going to happen to those patients who get transfused often and most likely have already an allo antibody. And it happens where we see a precipitous drop probably within 24 hours of receiving a transfusion, and it goes 25% below the pre-transfusion hemoglobin. And then we think it happens because there is a wonky immunologic response. Antibodies might get ramped up, they might not, but macrophages certainly do, and the complement system also is involved. And the first thing we should be doing is just making sure that we do hemolytic indices, that hemolysis is actually happening, that we've got the right patient, right test tube, our clerical checks are performed, and that this isn't an acute hemolytic transfusion reaction. It's also helpful to do some of the labs up front, looking at any vitamin deficiencies, and as you mentioned, metabolic disorders, things like that. But once this diagnosis is made, we need to alert the team, and we have to stop any transfusions from occurring. And then you and your team have developed this incredible protocol of what types of therapies to offer next. And, transfusions being the last resort,
Mhm.
and plasma exchange, maybe.
Yeah.
Maybe. But monitoring these patients super close in the ICU and helping them to get through this episode.
Yeah.
So tell me what I forgot.
What I think you covered it pretty well. I'll just say that like my motivation for working on the systematic review was we had a hyperhemolysis case, and
Yeah.
I said, oh, we should just read the systematic review and see what they do, and we couldn't find one.
Right.
So Jeremy Jacobs and Garrett Booth were incredibly helpful in putting that together and helping me with that. And then Ravi Sarodi really championed working on the How Do I paper. So thanks to him for sort of, goosing me to make that happen.
Absolutely.
I think the only other areas that we didn't touch on are kind of more areas that we don't know what the best thing to do is. Patients with a history of hyperhemolysis do tend to run into hyperhemolysis more frequently.
Okay.
So if you can do more of a patient blood management type approach, if they need their hemoglobin buoyed, maybe doing something like an erythroid stimulating agent or something to avoid transfusion if at all possible, or really pre-medicating with enough immunosuppression, not just IVIG, not just steroids, IVIG and steroids, and perhaps something else like eculizumab if you have to transfuse a patient. And then another difficulty that we sometimes run into, which was also highlighted in the systematic review, is that many of these patients are pregnant. There have been about 6 or 7 cases in the literature of pregnant patients with a history of hyperhemolysis. This is very difficult to manage, as some of these medications really may not be appropriate in
Mm-hmm.
pregnancy. So
Right.
working with your obstetrical colleagues as well as your hematology group to make sure that you're doing everything you can and protecting the patient as well as the baby.
Wow. Yeah. Interesting to also consider that patient population
Mm-hmm.
who already have some type of immunologic changes that occur during pregnancy, and maybe they become unmasked or escalated. So thank you for bringing that up. And
Mm-hmm.
yeah, that we should be paying attention to that as well. Wow. Well, you covered a lot. I feel enlightened by
Oh,
you
great.
today.
Hopefully we learned something.
I definitely did. We have participants listening in. Maybe we'll wait a few minutes if anyone has any questions or any of their own personal experiences. In the meantime, I want to thank you so much for coming today to speak with us, Dr. Atkins.
Oh, thank
It's
you so much,
always a
Dr. Hemlin.
pleasure. Always a pleasure. I kind of wish I could be a resident again and work with you, and send anybody your way to join residency and fellowship. It must be so interesting, and you learn so much. Otherwise, anything else that you want to leave us with?
No, I think the biggest thing, or yes, I do have one more thing, is just keep learning.
Mm-hmm.
Ultimately, the only time you're a know-it-all is whenever you think you haven't. The only time you're a know-it-all is when you think that there's nothing left to learn, but there's always something left to learn. So I'm continually a student. I don't know it all,
Mm-hmm.
and I think if you can lean on your colleagues and the literature as best you can, that you can get through these cases. And feel free to reach out. We occasionally have people reach out about hyperhemolysis cases. My email's out there. We recently got someone from Norway emailing us about a case, which I was really excited to share about. So
That is something wonderful
yeah.
about our transfusion medicine community,
Mm-hmm.
that we have each other. Each of us may have our own sort of like expertise niche, and that is so nice how you were able to help someone.
Yeah. So there are resources out there. You're not alone, especially everyone is so connected electronically these days.
Yeah.
So certainly, if you have questions, reach out, and just keep learning, keep doing your best.
That's a beautiful last sage words of advice. It's so nice. Yeah, to stay curious. And gosh, there's so much to learn.
Yeah.
Well, thank you for joining us again today. And thank you for all that you do and for writing the publication. And wish you the best.
All right. Hey, have a great day. I appreciate it.
Take care.